So friends, welcome to part 2 of arterial blood gas interpretation. Okay, so please watch part 1 before you come to this part so that you can be on the same page as us. So we said that when you get a strip, after you have done your ABG, now you are getting the results. So look at the pH. If your pH is more than 7.45, greater than 7.45, that's alkalosis. Alkalosis. You don't know whether it's respiratory or metabolic at this point, but what you know is that it's alkalosis. If the pH is less than 7.35, that's acidosis. You don't know whether it's respiratory acidosis or metabolic acidosis. So, like I said previously, then the next thing that you look at your partial pressure of CO2. Does your partial pressure of CO2 agree with your pH, which is acidic? A partial pressure of CO2 that agrees with acidity is a partial pressure that is more than 45. Down 45. A partial pressure of CO2 that is acidotic is a partial pressure of CO2 that is more than 45. For us to have acidosis from a partial pressure of CO2, it must be above 45. That's what I'm trying to say. So if we have acidosis as our pH, it can be 7.26, 27, 7.28, 7.34. That's acidosis. But now the next thing that we look at is the partial pressure of CO2. What is it doing? If we have acidosis, if our pH says we have acidosis, if the acidosis is because of a partial pressure of CO2, then the partial pressure of CO2 must be more than 45. Must be high. It must be high. It must be more than 5 to show that we are retaining CO2. And because we are retaining CO2, our CO2 in the blood, the partial pressure has increased, making our blood to be acidic. So if we have got an acidosis, as according to if we have acidosis according to our pH, and then we come to the partial pressure, and then we find that our partial pressure of CO2 is more than 45, then we know that that partial pressure of CO2, that acidosis is most likely respiratory. Right now I'm doing simple acid-base balances. I know there are complicated ones where there's compensation, no compensation, or partial compensation, or full compensation. All those things we're going to talk about maybe in part 3, part 4. So, but what I'm saying is, right at this point, is that when you have acidosis, like we have acidosis here, we know that we have acidosis because our number is less than 7.35. But we don't know whether it's respiratory or it's metabolic. So to determine that, we look at our partial pressure. If our partial pressure is more than 45, then we know that our acidosis is because of CO2 retention, which is a respiratory problem. But now, if we have acidosis but we look at our partial pressure like here, we have acidosis, but we look at we have acidosis. We know that we have got acidosis, but when we look at our partial pressure, we find it to be less than 35. We know that a reduced CO2 less than 35 cannot give us acidosis. We know that to have acidosis from CO2, it must be increased. So it means that for this patient, this is a patient who's got acidosis, but the partial pressure of this patient is less than 35. So this acidosis is not because of this CO2, because a CO2 of less than 35 should give you alkalosis instead of giving you acidosis. So we can say this acidosis is most likely a metabolic acidosis. Metabolic acidosis. Then what we can do, we're going to talk about it later though. Then you can go and check your bicarbs. What are your bicarbs doing in this case? But for this patient who's got acidosis and is returning CO2, we can confidently say that this one has got respiratory acidosis. This one. Okay, let's move on to the other side. So we have a patient. This patient has got a partial pressure of more than 45. Just want to use a different color here. Different color. So this patient now has got a pH of more than 7.45. By this by definition is alkalosis. We don't know what alkalosis it is. We don't know whether it's respiratory or it's metabolic. But what do? We look at our partial pressure of CO2 again. What is it doing? If on this patient we find that our partial pressure is less than 35, and we know that for us to have alkalosis from a respiratory point of view, then we must have reduced CO2. So this is most likely the cause of this alkalosis. It's most likely to be respiratory. Oh guys, let me do better. It's most likely to be respiratory. Look at what is happening here. We look at our pH, we say, okay, our pH is more than 7.45. Okay, we know it's alkalosis. But when we check our partial pressure, now our partial pressure is more than 45. By definition, we know that if you have got a partial pressure that is more than 45, that is increased, you should be having acidosis. You should be having acidosis if you have got this. So which means, so you should be having acidosis, but we are not having acidosis. We are not having acidosis. We are having alkalosis. So which means this is most likely a compensatory mechanism. So this is most likely a metabolic alkalosis, and this is just compensation. I hope you get that. Alkalosis. So what you can do, you can go and check your bicarbs. What is your bicarb doing? Remember, respiratory compensation compared to metabolic, the one that is more faster, that is more immediate, is respiratory. The renal takes a bit of time, because if you have got alkalosis in the blood, your pH is alkalotic, the kidney will try to get rid of CO bicarbonate through the urine to excrete it. That's what it's going to do. But it takes a couple of days for this to happen. So when you let me start this again. You look at a strip, you decide, okay, my pH for this patient is alkalosis. What is the cause of the alkalosis? Is it metabolic or is it respiratory? To answer that question, go and check your partial pressure of CO2. Now, for this particular patient, the partial pressure is more than 45. And we know that a partial pressure that is more than 45 should give us acidosis. But we don't have acidosis in this patient, we've got alkalosis. So this must be the compensatory mechanism. But the primary insult is metabolic alkalosis. So if you've got metabolic alkalosis, you go and check your bicarbonate. Your bicarbonate should be more than 27 to prove that the alkalinity or the alkalosis that you have is from this guy. So this guy should be very high. Maybe should be on the 30s, 30 something, even 40, depending how bad it is. So this should confirm for you. So the same thing applies. So what I'm trying to say to you guys, do this in a stepwise approach. I know this thing, it also gave me a lot of problems when I started to read when I was still a student. What I'm saying here, step 1, look at the pH. What is it doing? Okay, let me do it this way. Look at the pH. From your pH, decide if you are having acidosis or you are having alkalosis. Because the compensation and all those things, it becomes hard to understand if you don't understand this part. So you look at your pH. That's your step number 1. Look at your pH. Decide if it's acidosis or it's alkalosis. And then from there, so step number 1, check your pH. Decide if it's alkalotic or it's acidotic. So if it's acidotic, you know pH is less than 7.35. So pH is less than 7.35. Now look at your partial pressure to decide if you are having metabolic acidosis or respiratory acidosis. If this guy is high, meaning greater than 45, then that's a respiratory acidosis. But if this guy is low, most likely it's a metabolic acidosis, right? I'm going to talk about issue of compensation on another video. Okay, when you come to alkalosis, so it means pH is greater than 7.45, right? But decide if it's acidosis or if it's metabolic alkalosis or if it's respiratory alkalosis by looking at your partial pressure. If your partial pressure is low, less than 35, most likely it's a respiratory alkalosis. But if your partial pressure is high, most likely this is compensation, because it's not the cause of the alkalosis. So we're going to talk about compensation in another video, partial compensation and what they call high anion gap metabolic acidosis. Okay, before we talk about that, let's I want to show you something. When you look at it's just a small thing that I can just squeeze it in this video to avoid having a lot of videos, small segments. When you look at an ABG, there is also lactic acid there. Lactic acid. There's also lactic acid value there. You know, when you've got a high lactic acid in your blood, it is gonna make your blood to be acidic. This is like more like now looking at the cause and other things. So it's gonna make your blood to be acidic if you've got a high lactic acid. So it's gonna make your blood to be acidic. And what is the cause of a buildup of lactic acid in the body? Anaerobic respiration. Remember the Krebs cycle? There's a step in the Krebs cycle that produces lactic acid because of anaerobic respiration. So how do you produce anaerobic respiration? It means that there's a decreased O2, but the cells, they keep respiring. They keep respiring even though there's a decreased O2, and they respire in the absence of oxygen. What can cause oxygen to be low in the body? So, like I'm saying, you produce lactic acid when you respire anaerobically. So you are respiring, producing ATP without oxygen. So what are the causes of a decreased O2 or a lack of O2 to force the muscles to respire anaerobically? Okay, number one is decreased O2 itself, meaning patient has got low sets. Number two, if you've got a decreased blood volume, remember, okay, if you've got a decreased HB, so basically what you want to do, you have a cell, but what you want to do is to deliver O2 to this cell so that it can respire and give you ATP using oxygen. But now you don't have this guy. What are the causes of you not having, or what are the causes of you not being able to deliver oxygen to the cell? One of the causes could be that you don't have enough oxygen. Maybe the patient is not breathing well, so basically you've got low sets there. Maybe you've got enough oxygen, but the problem is your HB, you've got some kind of anemia, hemorrhagic anemia, whatever anemia it is. Or maybe these guys are fine, but the problem is that you've got reduced blood volume. Maybe you bled, maybe you vomited a lot, or maybe you had diarrhea, whatever that can reduce your blood volume. Because you can have 1 million red cells, but if you don't have enough plasma for the flow, you're gonna have stagnant blood that is not actually doing anything. So what I'm trying to say, basically, when you've got an increased lactic acid in your ABG, think about oxygen delivery. Are you having any of these? The other causes as well, obviously, but most of the times a patient who's got acidosis, and then they were bleeding, they're diarrhea, they're vomiting. Once you correct their blood volume and start delivering oxygen there, this one will self-correct. It's one of the things that when you take this maybe you take an ABG to your senior to interpret, and then they say to you, give this patient fluid. They don't say why give this patient fluid. It's most likely they're having a lot of acidosis, so they are behind. It's one of the things that you can use to see if the patient is behind in fluids or not. So, and then the minute you give them enough fluids, they start clearing the lactic acid, and then because you're delivering the O2 to the cells, they start now respiring aerobically and stop producing a lot of lactic acid. Thank you guys for watching. I'll meet you on another video, part 3 of this.